on the clinical webinar of the CEC. Today we have a special topic which is chronic aortic regurgitation, continuing our valvular heart disease track. We have a special guest, which is Dr. Ahmed Mohsen, lecturer of cardiology at Cairo University. He's also very famous for being the president of cardiology quizzes on the Facebook, and he has many followers all over the world. And we have moderation from two eminent cardiologists, Dr. Mahmoud Saraya, lecturer of cardiology at Cairo University, and Dr. Haytham Suleiman, lecturer of cardiology at Fayoum University. I'm sure we will enjoy the clinical webinar today, and I'd like Dr. Ahmed Mohsen to start his presentation now.
Thank you so much, dear Dr. Karim, for this very nice introduction. It's always a pleasure and a great honor to be part of the scientific activities organized by Cardiology Education Channel. Today, I will talk about practical approach for patients with chronic aortic regurgitation. Our agenda will include causes and the mechanism of aortic regurgitation, diagnosis of aortic regurgitation, stages and follow-up, management, either medical or surgical, and finally, aortic regurgitation in special situations. Let's start with causes and the mechanism of aortic regurgitation. The main etiology of aortic regurgitation divided into four main categories. The first category is congenital leaflet abnormalities, such as bicuspid aortic valve, unicuspid aortic valve, or quadricuspid aortic valve, or congenital heart disease, such as ventricular septal defect. The second category is acquired leaflet abnormalities, which include senile calcification, endocarditis, rheumatic heart disease, radiation-induced valvulopathy, or toxin-induced valvulopathy, such as anorectic drugs or carcinoid. The third category is congenital or genetic aortic root abnormalities, which include annulo-aortic ectasia and connective tissue disorder, such as Lewis-Dietz syndrome or Ehlers-Danlos syndrome, Marfan syndrome, or osteogenesis imperfecta. And finally, the last category is acquired aortic root abnormalities, which include idiopathic aortic root dilatation, systemic hypertension, autoimmune disease such as systemic lupus, ankylosing spondylitis, Reiter syndrome, and aortitis such as cephalitis, cephalitic aortic regurgitation, or Takayasu arthritis, aortic dissection, or trauma. What is the mechanism of aortic regurgitation? The mechanism of aortic regurgitation is similar to the mechanism of the mitral regurgitation. We have three main mechanisms. The first one is normal cusp motion with aortic dilatation or cusp perforation. And this type 1 is subdivided into four categories. The first category, which is type 1A, involve the dilatation of the aortic root and the whole ascending aorta. Type 1B, dilatation of the sinuses of valsalva and sinotubular junction. Type 1C, dilatation of the aortic annulus. Type 1D, which include aortic perforation. Type 2 include cusp prolapse. Type 3 include cusp restriction, such as rheumatic or sclerotic aortic valve disease. Let's see some practical examples of severe aortic regurgitation. The first example is infective endocarditis. We can appreciate on the 2D image the presence of aortic vegetation, and on the right side we can see severe aortic regurgitation. The second example is rheumatic heart disease. We can appreciate the presence of mitral stenosis with doming of anterior mitral leaflet and calcification, and also rheumatic affection of aortic valve with eccentric aortic regurgitation. The third example is flail right coronary cusp. This is a TEE study, three-chamber view. We can see a vegetation with flail right coronary cusp and subsequent severe aortic regurgitation. And this is a nice example of subaortic membrane with eccentric aortic regurg caused by injury to the aortic leaflet by the pressure overload pattern caused by the subaortic membrane. And this is a nice example for aortic processes with significant valvular and paravalvular aortic regurgitation. And this is the famous bicuspid aortic valve. We can see two cusps with raphe. And on the right side, we can see the characteristic M mode with eccentric closure line. The second part of our lecture is about diagnosis of aortic regurgitation. According to the American College of Cardiology Guidelines 2017, transthoracic echo is indicated in patients with symptoms or signs of aortic regurgitation for accurate diagnosis and estimation of the regurgitation severity and the assessment of left ventricular function and dimension. Transthoracic echo is also indicated in patients with dilated aortic sinuses or ascending aorta or bicuspid aortic valve to evaluate the presence and the severity of aortic regurgitation. CMR or cardiac MRI is indicated in patients with moderate or severe aortic regurgitation with suboptimal echocardiographic images for assessment of the left ventricular systolic function, systolic and diastolic volume, and assessment of aortic regurgitation severity. Additional testing with transesophageal echo or cardiac MRI is indicated when transthoracic echo is suboptimal in patients with suspected aortic regurgitation, the mechanism of aortic regurgitation is unclear, there is a discrepancy between the echo parameters and the Doppler parameters or the clinical finding and the echo finding, aortic root and ascending aorta need a better assessment, or a discrepancy between the transthoracic echo and the clinical finding, as we said before. When aortic regurgitation is detected, the evaluation starts with assessment of the anatomy of the aortic valve, aortic root, to determine the etiology and the mechanism of regurgitation, followed by assessment of left ventricular size, left ventricular geometry, and left ventricular function. It should be noted that no single measurement or Doppler parameter is precise enough to quantify aortic regurg in individual patients. Integration of multiple parameters is required. The severity of aortic regurgitation can be graded using a combination of structural, qualitative, Doppler, and semi-quantitative parameters. To grade the severity of chronic aortic regurgitation by echo, we have to look for the following: structural parameters, qualitative Doppler parameters, semi-quantitative parameters, and finally quantitative parameters. Structural parameters include aortic leaflet assessment. If we have a flail valve or wide coaptation, this is suggestive of severe aortic regurgitation. and we should look for the left ventricular dimension. If we have a dilated LV, then we are talking about severe aortic regurgitation. The second item is the qualitative Doppler parameter, which includes the jet width in the LVOT by the color flow. If it is large jet and central jet, this is suggestive of severe aortic regurgitation. If we have a dense continuous wave Doppler, suggestive of severe aortic regurgitation. And finally, the pressure half time less than 200 milliseconds is suggestive of severe aortic regurgitation. And very important, the holodiastolic flow reversal in descending aorta and even in abdominal aorta are very important signs of severe aortic regurgitation. The semi-quantitative parameters include the vena contracta width, 0.6 centimeter is the cutoff value for severe aortic regurgitation. Jet width in relation to the LVOT width, if more than 65% is suggestive of severe aortic regurgitation. And finally, the quantitative parameters, which include the regurgitation volume and regurgitation fraction and effective regurgitant orifice area. How to interpret?
Ahmed,
أيوة.
I'm terribly sorry to interrupt, but Dr. Karim asked an important question. Is the classification helps in differentiating the etiology or has an impact on the surgical management?
Yes.
And can severe aortic regurg present without left ventricular dilation or not?
Thank you, Dr. Haitham and Dr. Karim, for this nice question. The first question is about the mechanism of aortic regurgitation. Yes, it can affect the management, as in cases of aortic valve prolapse or aortic root dilatation, we can go for aortic valve repair. While in rheumatic cases or severe valve damage or flail valve not feasible for repair, we have to replace the valve. This is the first question. The second question is about the left ventricular dilatation. Almost always chronic severe aortic regurgitation present with dilated LV. If you don't have a dilated LV, you should look for the indexed dimension. If the indexed dimension is not fulfilling the criteria for left ventricular dilatation in aortic regurgitation, I think we have to revise the severity of aortic regurgitation. I will explain here also the criteria for severe aortic regurgitation. We have many criteria for severe aortic regurgitation, but if we have a flail valve, vena contracta width more than 0.6, central jet and the jet involve more than 65% of the LVOT width, pressure half time less than 200 milliseconds, holodiastolic flow reversal in the descending aorta, enlarged LV with normal function. If we have a 4 criteria from the previously mentioned criteria, then we have a definite severe aortic regurgitation. If we have only 2 or 3 criteria, then we have to look for the regurgitation volume and the regurgitation fraction and the effective regurgitant orifice area. I think it is clear now how to determine the severity of aortic regurgitation. The third part is stages and follow-up. The general staging of progression of valvular heart disease according to the American College of Cardiology Guidelines 2017 is divided into 4 stages. The first stage or stage A is at risk. Patient has a risk factor for development of valvular heart disease. Stage B, progressive valvular heart disease include mild or moderate valvular regurgitation and asymptomatic. Stage C, asymptomatic severe, which is subdivided into C1, asymptomatic severe with normal LV, C2, asymptomatic severe with abnormal LV, and finally, symptomatic severe, which is stage D. How to apply this classification on aortic regurgitation? Stage A, at risk of aortic regurgitation, such as patients with bicuspid aortic valve or other congenital valve anomalies, aortic valve sclerosis, diseases of aortic sinuses or ascending aorta, history of rheumatic fever or non-rheumatic heart disease or infective endocarditis. Stage B, progressive aortic regurgitation, which include the same valvular anatomy, but with mild aortic regurg or moderate aortic regurg. Still, we have a normal left ventricular function and the dimension. Stage C, asymptomatic severe aortic regurgitation, which is subdivided into C1, normal ejection fraction and mild to moderate left ventricular dilatation, end systolic dimension less than 50 millimeter, and C2, abnormal left ventricular systolic function with depressed ejection fraction less than 50% or severe left ventricular dilatation, left ventricular end systolic dimension above 50 millimeter or indexed end systolic diameter above 25 millimeter per meter square. And in this stage, we can consider exercise testing to confirm the symptom status. Finally, stage D, symptomatic severe aortic regurgitation with the classic symptom including exertional dyspnea or angina or severe heart failure symptoms, which is a classic indication for aortic valve intervention, either repair or replacement. What about the frequency of echo in asymptomatic patients with valvular heart disease and normal left ventricular function? If we have a patient with mild aortic regurg, we should ask for follow-up echo every 3 to 5 years. If we have a moderate aortic incompetence, we should ask for follow-up echo every 1 or 2 years. If we have a severe aortic regurgitation with normal LV, we should ask for follow-up echo every 1 year with abnormal LV every 6 months. The fourth part of our lecture is about management, which include medical or surgical management of aortic regurgitation.
I'm terribly sorry, Ahmed, for the continuous interruption. But there is a question also from Dr. Karim. Which Doppler method would you find most useful for grading severity of aortic regurg?
Which Doppler method? Okay. To be honest, I don't depend so much on the Doppler in assessment of severity of aortic regurgitation. I depend mainly on the vena contracta and jet widths to the LVOT widths and the holodiastolic flow reversal in the descending aorta and the left ventricular dimensions. For me, all the Doppler-derived parameters are almost of the same efficacy or sensitivity as regard the assessment of severity, either regurgitation fraction or regurgitation volume or effective regurgitant orifice area. And all these parameters are considered as a second line if we don't have a 4 criteria of the previously mentioned criteria, which include a flail valve and vena contracta and the abnormal LV dimension, holodiastolic flow reversal, jet widths. If we don't conclude the severity from these parameters, we should go for the second line parameters, which is the Doppler derived parameters, either regurgitant fraction or regurgitant volume or effective regurgitant orifice area. Even pressure half time has a lot of fallacies. In aortic regurgitation, we must have a single valve lesion in presence of other valvular affection. It will affect the results of a pressure half time. And pressure half time has a value mainly in acute aortic regurgitation, but in chronic aortic regurgitation, many cases with severe aortic regurgitation, I see pressure half time in the range of the moderate severity, despite the clear severe aortic incompetence by other criteria.
Okay, and you've mentioned the follow-up of aortic regurg.
Yes.
What about the follow-up of aortic root dilatation? If it's not suitable for intervention now,
Yes.
if there is a particular schedule for following up the aortic root dilation?
Sure. The follow-up of aortic root dilatation depends on the etiology of the aortic root dilatation. It would be different from cause to another. If the cause is a Marfan syndrome or bicuspid aortic valve, these two causes are risk factors for aortic dissection or aortic progressive aortic dilatation. So the follow-up will be more frequent. Actually, the American College of Cardiology recommend annual follow-up of the aortic root dimension if patients has a bicuspid aortic valve and aortic root is above 4.5 centimeters. And the Marfan syndrome, I think we can apply the same rule, if not more frequent. I will talk about this also in the management.
Okay.
The basic principle of the medical therapy includes the secondary prevention of rheumatic fever if the etiology is rheumatic heart disease, and the endocarditis prophylaxis, including the famous indication for prophylaxis against endocarditis, but before a certain procedure, which is the dental procedure that involve an manipulation of the gingiva or the periapical region or the oral mucosa. If the patient has a prosthetic valve or prosthetic material used for cardiac valve repair, such as annuloplasty, ring, and cords, previous endocarditis, unrepaired cyanotic congenital heart disease, or repaired congenital heart disease with residual shunt or valvular regurgitation at the site or adjacent to the site of the prosthetic patch or prosthetic device. And finally, the cardiac transplant with valvular regurgitation due to structurally abnormal valve. But according to the American College of Cardiology guidelines, prophylaxis against endocarditis is not recommended in patients with valvular heart disease for the non-dental procedure, including the TE or the GI endoscopy or cystoscopy in absence of active infection. The medical therapy also include treatment of hypertension if the systolic blood pressure is above 140 millimeter mercury. The treatment of hypertension is recommended in patients with chronic aortic regurgitation, preferably with dihydropyridine calcium channel blocker or ACE inhibitor or ARBs. Medical therapy with ACE inhibitor ARPs and the beta blocker is reasonable in patients with severe aortic regurgitation who have symptom or left ventricular systolic dysfunction when surgery is not performed because of comorbidities. What about the surgical management of our chronic aortic regurgitation? At first, we should look for the significant enlargement of the ascending aorta. If we have a significant enlargement of the ascending aorta, we should go for surgery. If we don't have a significant enlargement of the ascending aorta, then we have to look for presence of severe aortic regurgitation. If we have a severe aortic regurgitation with symptom, we should go for surgery. If we don't have symptom, we should look for the left ventricular function and the dimension. If the left ventricular ejection fraction is less than 50%, or the end diastolic is above 70 millimeter, or end systolic is above 50 millimeter, or the end systolic is above 25 millimeter per meter square, we should go for surgery. Let's go for the details. Indication of surgery in severe aortic regurgitation according to the European Society of Cardiology Guidelines 2017. Surgery is indicated in symptomatic patients with severe aortic regurgitation or asymptomatic, but we have ejection fraction less than 50%, or severe aortic regurgitation in patients undergoing cardiac surgery, such as CABG or surgery for the aorta or another valve. Or surgery should be considered in asymptomatic with resting ejection fraction above 50, but with severe left ventricular dilatation, including the end diastolic dimension above 70, the end systolic dimension above 50, or the end systolic dimension indexed to the body surface area above 25 millimeter per meter square in patients with a small body size. What about moderate aortic?
Ahmed, there is an interesting question. In every step, we are evaluating our decision according to the severity of the aortic regurg.
Yes.
So what if we have a condition that underestimate or overestimate the severity of the aortic regurg? This is an interesting question from the YouTube. Dr. Rina is asking which conditions can lead to over or underestimation of the aortic regurg severity. How does the mitral stenosis affect the severity? Why it leads to overestimation of the aortic regurg, and how to overcome this issue? This is an important question because in every step, we are depending on the estimation of the aortic regurg to lead the decision whether the medical treatment or the surgical intervention. So if this is a condition kept in mind that we have an additional structural defect that can affect the estimation of the severity?
Okay, very nice question. Thank you, Dr. Haitham. As I said before, the gold standard is not to depend on a single parameter. This is the gold standard. You have to correlate your clinical finding with your echocardiographic finding. We have about 10 criteria for assessment of aortic regurgitation. So I don't depend on single parameters. If we have an eccentric jet, then you have to go for transesophageal echo to assess the severity in a better way. If the echo is not conclusive and there is a discrepancy between the echo finding and the clinical finding, you are justified to go for cardiac MRI. Cardiac MRI is very helpful in borderline cases or doubtful cases. It allows accurate assessment of the left ventricular volumes, left ventricular ejection fraction, And even we can assess the severity of aortic regurgitation by accurate assessment of regurgitation volume and regurgitation fraction. So if you have an inconclusive echo study due to multiple valvular abnormalities, poor echo window, eccentric jet, then your weapon is the TE or better cardiac MRI.
Okay,
I hope
thank
it
you,
is
dear.
clear now.
Yes, thank you.
Thank you. What about patients with moderate aortic regurgitation and he is referred for other cardiac surgery? The American College of Cardiology recommend aortic valve replacement in patients with moderate aortic regurg who are undergoing other cardiac surgery as a class 2A indication. The second part of the indication of surgery in severe aortic regurgitation and aortic root disease is aortic aneurysm or aortic root dilatation, irrespective of the severity of aortic regurgitation. Aortic valve repair using the reimplantation or remodeling of the aortic with aortic angioplasty technique is recommended in young patients with aortic root dilatation and the tricuspid aortic valve when performed by experienced surgeon. Surgery is indicated in patients with Marfan syndrome who have aortic root disease with maximal ascending aortic diameter above 50 millimeter as a class 1 indication. What about the class 2A indication? Surgery should be considered in patients who have aortic root disease with maximal ascending aortic diameter above 45 millimeter in patients with Marfan syndrome with additional risk factor. The additional risk factor includes severe aortic incompetence, severe mitral incompetence, desire for pregnancy, systemic hypertension, or the increase in the aortic size more than 3 millimeter per year. And the same rules applied in patients with transforming growth factor beta 1 or beta 2 receptor mutation, including the Lewis-Dietz syndrome. The cutoff value in patients with bicuspid aortic valve with additional risk factor or coarctation is 50 millimeter. Other patients, other than Marfan syndrome and bicuspid aortic valve, the cutoff value is 55 millimeter. When surgery is primarily indicated for the aortic valve, replacement of the aortic root or the tubular ascending aorta should be considered when the aortic root is above 45 millimeter, especially in presence of bicuspid aortic valve. What about the choice of the aortic prosthesis? Should we implant a mechanical valve or a tissue valve? Mechanical prosthesis should be considered in patients who are already on anticoagulation for another indication. Mechanical prosthesis should be considered in patients who are below 60 for prosthesis in aortic position. Patients who are below 60 years, we should consider implanting a mechanical prosthesis. While we should implant a bioprosthetic valve when there is a contraindication for anticoagulation because of high risk of bleeding, or young women with desire for pregnancy, or patients who is above 65 years. The last part of our lecture is about the special situation.
Good evening, Dr. Ahmed. Excuse me for the interruption. This is Mahmoud Sarai with you.
Welcome, Dr. Mahmoud.
Hi, how are you?
I am
sorry for the delay. I'm just having some traffic problems, so I'm just with you.
Never mind. Never mind.
Okay. Excuse me, before turning to the next section, I would like to ask you, you didn't mention any idea or any thing about the option for repair. We are discussing the guidelines, I understand, but there is some room for aortic valve repair in some certain population.
Yes, I have mentioned it.
Yes, but I want to ask you, do you have any criteria you guide the surgeon to go for repair? Especially, I know that you are a 3D echocardiographer and you have much experience in this. So, do you have any certain parameters that can guide the surgeon, or just leave this to the surgeon experience and his decision and the heart team decision?
Okay, very nice question, Dr. Mahmoud. I think the best candidate for aortic valve repair is patients with aortic valve prolapse or aortic root dilatation with malcoaptation of the aortic leaflet. In these two particular situations, the results of aortic valve repair by experienced surgeon in an experienced center is very good. In other situations, rheumatic valve disease or edge-related valve disease with a lot of thickening and a lot of calcification, the repair is not feasible in most cases.
Okay, Ahmed, go ahead, Sarai.
Okay, thank you, Dr. Ahmed. That's very clear. Thank you.
Thank you, Dr. Mahmoud.
Okay, first of all, we would like to welcome our brother, Dr. Mahmoud Saraya. He's missed in Egypt, and we are very pleased to have him on board. Second of all, before leaving the section of management, there is two questions about it. The first one is the role of transcatheter aortic valve replacement in the management of aortic regurg. It might be a primitive question, but why not to try, or there is any trials of using the aortic valve, transcatheter aortic valve replacement in treating aortic regurg, unlike the treatment of the aortic stenosis, or not? So what's
okay. Thank you, Dr. Haitham, for this nice question. Actually, the idea is not new. The main concern for transcatheter aortic valve replacement in patients with aortic regurgitation is the stability of the valve in aortic position. Many patients with aortic regurgitation have some degree of aortic root dilatation, which prevent adequate stabilization of the valve in aortic position. But I think with more development of the valve and more development of the technique, it may be considered in the future. Why not?
Okay. And the second issue is in the bioprosthetic valves. We know that there is an indication of using anticoagulation in the bioprosthetic valve. Is it a must to do it, especially that we are choosing the bioprosthetic valve in patients that are not suitable for anticoagulation, or patients who are seeking, females that are seeking pregnancy, so the anticoagulation will not be suitable for them. So, and then we have a recommendation from the European and the American Society of using anticoagulation in these patients. So is it a must, or there is a high risk of thrombosis in bioprostheses if we do not use anticoagulation, or not?
Very nice question. Actually, the tissue valve in aortic position, you can give antiplatelet instead of the anticoagulation. And this is the only exception for the tissue valve. Tissue valve in mitral or tricuspid position, you must give oral anticoagulation for 3 months. But tissue valve in aortic position, you can give either antiplatelet or anticoagulation. So this is a very unique advantage for the tissue valve in aortic position.
I think we have another special situation that you did not mention in your agenda is the threshold of aortic root replacement in aortic root abscess.
Okay, aortic root abscess is a part of the endocarditis management. And if we have a patient with infective endocarditis with aortic root abscess, either with dilated aortic root or with normal aortic root, this is a direct indication for surgery, as these patients will not respond for antibiotic therapy, and you have to surgically drain the abscess, then replace the valve or repair the valve according to its damage.
So the presence of aortic root abscess is an indication for aortic root replacement in every patient, or valve replacement?
Is indication for surgery, and we manage according to every patient. If we have some patients with aortic root dilatation and with a cutoff value necessitating Pental operation. Other patients, we can only drain the abscess and replace the valve only. Some patients are complicated by rupture aortic root abscess in the RVOT or in the or even fistulous communication with any cardiac chamber. I think in these cases we do repair for the aortic root.
So it's about the invasion of the aortic abscess,
yes,
its complication, and
yes,
its effect on the aortic root dilation that indicates the aortic root replacement or not.
Exactly.
Okay.
Exactly.
Thank you so much.
You are welcome. The last part is the special situation, which include four main categories: aortic regurgitation in patients with atrial fibrillation, aortic regurgitation with coronary artery disease, aortic regurgitation in pregnancy, and aortic regurgitation in patients referred for non-cardiac surgery. Let's start with atrial fibrillation and aortic regurgitation. Can we give NOAC, or we should give warfarin? It should be clear that aortic regurgitation is not a part of the valvular AF. Valvular AF include mechanical prosthesis or moderate or severe mitral stenosis. So you can give NOACs in patients with atrial fibrillation and aortic regurgitation according to the CHA2DS2-VASc score. This is a very important message. In patients with AF and aortic regurgitation who are referred for surgery, you should consider surgical ablation of atrial fibrillation and surgical excision or external clipping of left atrial appendage. The second special situation is aortic regurgitation with coronary artery disease. If we have a patient with severe aortic incompetence who is indicated for aortic valve replacement or aortic valve repair, coronary angiography is recommended before valve surgery in patients with severe valvular heart disease and any of the following: history of cardiovascular disease, suspected myocardial ischemia by the non-invasive assessment or by symptoms or by the risk factors, left ventricular systolic dysfunction, male above 40 or post-menopausal female. And the CT coronary angiography is only alternative for the invasive diagnostic coronary angiography if it was not feasible to do invasive coronary angiography. If we found a coronary artery stenosis above 70% in patient who is indicated for aortic valve surgery, then CABG is a class 1 recommendation if the coronary artery stenosis is above 50%, then CABG is a class 2A indication together with the aortic valve surgery. Aortic regurgitation with pregnancy. Chronic aortic regurgitation is well tolerated even when severe, provided that the left ventricular systolic function is preserved. Exercise test is reasonable in asymptomatic patients with severe aortic regurgitation before pregnancy, according to the American College of Cardiology Guidelines 2017. The European Society of Cardiology recommend surgical treatment before pregnancy in patients with severe aortic regurgitation who are either symptomatic or have a left ventricular dysfunction or dilatation. And the European Society recommend medical therapy in pregnant women with regurgitation lesion when symptoms occur during pregnancy. However, the American College of Cardiology guidelines recommend valve operation during the pregnancy if there is an EHA class 4 heart failure symptom that is refractory to the medical treatment. Valve operation should not be performed in pregnancy if there is no refractory heart failure symptom. And of course, ACE inhibitors and ARBs is given to pregnant patients with the lesion. The last special situation is aortic regurgitation with non-cardiac surgery. According to the American College of Cardiology Guidelines 2017, moderate risk elective non-cardiac surgery with appropriate intraoperative and post-operative hemodynamic monitoring is reasonable to perform in patients with asymptomatic severe aortic regurgitation with normal LV. According to the European Society of Cardiology guidelines, non-cardiac surgery can be performed safely in asymptomatic patients with severe aortic regurgitation and preserved LV. The presence of symptoms or left ventricular dysfunction should lead to consideration of valvular surgery, but this is seldom needed before non-cardiac surgery. If the left ventricular dysfunction is severe with ejection fraction less than 30%, non-cardiac surgery should be performed only if strictly necessary and after optimization of heart failure medical treatment. Thank you so much.
Thank you, Dr. Ahmed. That's very elaborative and illustrative at the same time.
But thank you so much, Dr. Mahmoud.
Some questions are here on the road so that we can start with from the audience, please.
Sure.
We need, somebody is asking whether in the presence of mitral stenosis and the aortic regurg, what is your plan of management and how would you treat such a condition, especially in multiple valvular affection?
Okay, patients with aortic regurgitation and the mitral stenosis, the only trick is not to depend on the pressure half time, as it will be misleading in the assessment of the severity, and it depends on the severity of each valve. If we have a severe mitral stenosis with severe aortic incompetence and the patient is symptomatic, then we have to go for a surgical replacement of the mitral and the aortic valve. It will be different from another patient who have significant mitral stenosis with a Wilkin score of 7 and a mild or even moderate aortic regurgitation. We can consider balloon valvuloplasty for the mitral valve and go for follow-up for the aortic incompetence. The major advantage in the pathology of aortic regurgitation is the rate of progression. The rate of progression of aortic regurg is very slow. You need many years to go from mild to moderate severity or from moderate to severe aortic incompetence. So if you have a moderate aortic incompetence with normal LV and severe mitral stenosis and symptoms attributed to the mitral stenosis feasible for valvuloplasty and the normal left ventricular dimension, I will go for balloon and follow-up of the aortic regurgitation.
Okay, thank you. This comes to makes me think about another issue, which is how can you, in some people with aortic stenosis, with aortic regurgitation, there is an associated aortic stenosis. Okay, how can you use the echo and the tips and tricks for having a discrimination or identification between whether this is a flow murmur or a true aortic stenosis by echocardiography?
A flow murmur, yeah, okay. We have to look for the valve itself. Flow murmur means that we don't have a pathological regurgitation. By echo, you will see when you see a regurgitation by echo, this is not a flow murmur. This is a pathological finding. And you should look for the status of the valve itself. Is the valve second calcified, restricted, prolapse, perforation, rheumatic affection, aortic root dilatation, bicuspid aortic valve? All of these criteria can help you to differentiate between the both conditions.
You mean you depend on the morphology mainly? The morphology
yes.
can help, but
yes.
not on the hemodynamics of the valve.
As I said, flow murmur is a clinical finding, but it is not an echo finding. When you find a regurgitation by echo, this is a true regurgitation.
No, maybe I didn't. I mis-questioned you. What I ask about is when you have combined aortic regurgitation and aortic stenosis. Sometimes in severe aortic stenosis, aortic regurgitation, the gradient, the systolic gradient increases due to the increased flow across the aortic valve.
Okay.
How can
you mean that the gradient is overestimated due to the presence of aortic regurgitation?
Okay. Yes, and at that time, sometimes we can send the patient earlier than expected to surgery.
Yes, I get your point. Actually, I did an echo for a patient last Sunday with a similar example. I found a mean gradient across the aortic valve 32 millimeter mercury. However, the valve opening in the 2D in parasternal long axis and short axis is very good. Only mild restriction of the leaflets. There is a discrepancy between the aortic valve opening and the aortic valve leaflet excursion and the gradient across the aortic valve. I called the resident and asked about the history. The patient had a severe anemia with hemoglobin 6 and hyperdynamic circulation. So whenever you find a discrepancy between the aortic valve opening or excursion in parasternal long axis and short axis and the gradient in the apical 5, look for severe aortic incompetence or hyperdynamic circulation or anemia or dehydration or pregnancy or whatever, and correct the underlying condition, then reassess the gradient.
Okay, then you have to collaborate with the clinical findings and depend on other parameters, not necessarily to depend on the hemodynamics? That's a great question.
Yes.
Another question here is for the reverse remodeling for the left ventricle. Okay. Following valve replacement or repair or intervention by any means. What do you expect after having your patient changing the valve?
Actually, I have seen some patients with regression of the left ventricular dimension following valve surgery. It depends on the stage of the disease. If the surgery is performed early, the regression is much more expected, as if we compared it with a patient with a long-standing pressure, volume overload and marked left ventricular dilatation. Actually, the prognosis is better for patients who have end-diastolic dilatation if we compared with the patients with left ventricular end-systolic dilatation. So some patients have regression and some patients don't, according to the stage of the disease and the timing of intervention. If the intervention is early, I think the regression is expected, together with the ACE inhibitor and the beta blocker, of course.
Okay, Ahmed, there is another question from YouTube. In eccentric aortic regurg, the jet may restrict the anterior mitral leaflet, making the estimation of the aortic of the mitral stenosis more severe. So, in the presence of combined aortic regurg and mitral stenosis, how would you assess accurately the degree of mitral stenosis?
Okay. This is called Austin Flint murmur, and if the jet is posteriorly directed towards the anterior mitral leaflet, we can observe a premature closure of the mitral valve and the fluttering of the anterior mitral valve leaflet. But I don't think this can affect the severity of mitral stenosis, as we can assess the mitral valve area in short axis and in another in multiple views, and taking the dimension and taking the gradient across the mitral valve pressure half time will not be helpful in such cases. Looking for the morphology of the mitral valve, is there a marked restriction of the posterior leaflet which is away from the aortic regurgitation jet or not? Is there a calcification, thickening? So the same rule depend on multiple parameters, and you can reach a final conclusion. When you are in doubt, you should ask for another imaging modalities such as the TE or cardiac MRI.
Okay,
but is there? Sorry, Doctor.
Go ahead, dear.
Sorry, but is there any role for 3D echo to identify this issue, this mitral stenosis?
Of course, mitral 3D echo can help in accurate estimation of the mitral valve area, and you can calculate the 3D vena contracta for the aortic regurgitation. You can calculate the left ventricular volumes and ejection fraction. So, of course, the 3D echo can be helpful in these cases.
Okay, there is an important question from Dr. Hatem Sukari. What's your decision about the presence of combined severe mitral stenosis, moderate mitral regurg, and moderate aortic regurg? There is an indication here for replacement of the mitral valve or a surgical intervention for the mitral valve. So what's your decision
Yes, it
for
is.
the aortic valve.
Yes, it is not clear in the European guidelines, but in the American guidelines, they clearly stated that if you have an indication for cardiac surgery and you have a moderate aortic regurgitation, it is a class 2A to replace the aortic valve.
Okay, so you're voting for replacement of the aortic valve according to the American. It's more convenient than the European.
Together with the mitral valve, yes.
Okay. Dr. Mahmoud, do you have any question for Dr. Ahmed?
May I have a question, Dr. Ahmed?
Of course, Dr. Hatem.
I'm Dr. Hatem. Regarding the pregnancy, الأول السلام عليكم. How are you? You said during pregnancy we proceed for aortic replacement prior to pregnancy if there is left ventricular dysfunction or ventricular dilatation. What do you mean for this?
No.
This is
no. According to American College of Cardiology guidelines, if you have a refractory heart failure despite medical treatment in pregnancy due to valvular regurgitation, you can consider valve surgery.
Before pregnancy.
And only medical treatment during the pregnancy for the valve surgery. But before pregnancy, if we have severe aortic regurg, LV, you should go for aortic valve replacement or aortic valve repair before.
Same parameters as asymptomatic aortic regurg management.
Guidelines says another option. If we have a refractory heart failure due to valvular regurgitation during a pregnancy,
Ahmed, are you there with us?
أنا interrupted. أنا افتكرت إنه عندي.
No. I think Ahmed has a problem and he will join us soon. So let's discuss the control of hypertension in patients with aortic regurg till Ahmed rejoin us. We know for sure that one of the prevalent antihypertensive agent in our practice is beta blocker. But what do you think about this choice when managing?
Sorry for the interruption.
Hello back.
Thank you so much.
Okay, continue, please.
So during a pregnancy, if we have a refractory heart failure symptoms due to aortic regurgitation, American Society of Cardiology recommend aortic valve replacement. If the heart failure is responding for medical treatment, then continue medical treatment.
Okay.
But avoid use ACE or ERPs during pregnancy as they are teratogenic, of course.
Okay, Ahmed, we were discussing the management of hypertension in the presence of aortic regurg.
Yes.
The guidelines did exclude the beta blockers.
The guidelines recommend dihydropyridine, calcium channel blocker, or ACE inhibitor or ERB as a first choice. As you know, beta blocker is not preferred in patients with aortic regurgitation as it slows the heart rate, and this is will increase the regurgitation severity during the diastole. So the preferred antihypertensive in patients with aortic regurgitation is either dihydropyridine, calcium channel blocker, or ACE inhibitor or ARBs.
So we will come to the dilemma of the presence of aortic regurg in ischemic patients.
Yes.
Here we have two contradictories. One of them is to use agents to slow the heart rate, which is beneficial for ischemic heart disease, and the other that the use of any heart rate slower will increase the aortic regurg. So
Yes.
what's your opinion in this critical situation?
Yes, balance is very important in such cases. You give full anti-ischemic measures. In patients with isolated coronary artery disease, it is better to keep the resting heart rate below 60 or even to 55. But in patients with aortic regurg, I think the heart rate of 70 is reasonable to reach the balance between the coronary artery disease benefit and to avoid the risk of excessive reduction of heart rate as regard aortic regurgitation. And you can control symptoms by using other anti-anginal drugs such as nitrates or trimetazidine or etc.
Yes, I would like to add that beta blockers can also be used in aortic root dilatation, and also the losartan, especially for delaying the progression of the aortic root dilatation,
in patients with
especially
Marfan syndrome and in patients also with bicuspid aortic valve, you can consider giving a losartan or beta blocker to decrease the progression of aortic root dilatation. You are right, Dr. Mahmoud.
Okay, do we have more questions here? Yes, final question, I think. The use of the PISA effective regurgent orifice and regurgent volume and fractions, when do we use them and how to use them in the echo?
How to use them? This is need a separate lecture. This is a very complicated issue.
Yes, we need this one.
And it needs illustration. It can't be explained by verbal saying. And we can arrange for a dedicated lecture for echocardiographic assessment of aortic regurgitation.
So there is any special drugs, Ahmed, to delay the progression of aortic root dilation?
Yes, as I have said, and Dr. Mahmoud have said, losartan and beta blocker, especially in patients with Marfan syndrome, and this recommendation is extrapolated to patients with bicuspid aortic valve, especially the beta blocker. But the strongest evidence is for Marfan syndrome. Losartan and beta blocker can delay the progression of aortic root dilatation.
Any other questions?
We don't have here any more questions, I think.
So thank you so much, dear Dr. Ahmed.
Thank you so much, dear Dr. Aysam.
This is, as always, a very elegant and useful, illustrative talk, as we are used from you.
Thank you so much.
And it's always an honor. You are a member of the CEC. You are, and you are always
great honor for me, Dr. Aysam.
The honor is ours. Okay, Ahmed, any final statements regarding the EPUB?
Yes, I think to conclude this lecture in a few minutes, it is always important to define the etiology of the aortic regurgitation. I found many echo reports without a clear etiology for the aortic regurgitation. That is, the etiology of the aortic regurgitation will affect the management. As we have said, if we have a prolapse, we can consider repair and we can avoid all the complications of oral anticoagulation. The second message is it is always important to assess the aortic root in patients with bicuspid aortic valve, patients bicuspid aortic valve, commonly aortic valve, and it is very important not to depend on a single parameter to assess the aortic regurgitation severity, rather depend on all parameters and collect at least 4 criteria from the solid criteria for assessment of aortic regurgitation, such as the valve status, including the flail valve, the vena contracta, the jet width to the LVOT width, the holodiastolic flow reversal in the descending aorta, and the left ventricular dimension. If these criteria didn't conclude the severity, then go for the effective regurgitant orifice area and the regurgitation volume and the regurgitation fraction. No wax can be considered and can be given in patients with aortic regurgitation with atrial fibrillation according to the CHA2DS2-VASc score. If we have as asymptomatic severe aortic regurgitation, we can go for non-cardiac surgery, provided that the left ventricular function and the dimension are normal. If we have asymptomatic severe aortic regurgitation before pregnancy, we can consider exercise test to evaluate the symptom status. If we have a severe symptomatic aortic regurgitation or severe aortic regurg with abnormal LV, then you have to replace the aortic valve or to go for aortic valve repair before considering a pregnancy. And I think this is the most important points in our lecture today.
Thank you so much, Ahmed.
Thank you so much, Dr. Mahmoud and Dr. Haitham.
Thank you, Dr. Ahmed. That was expected, and even we are so enthusiastic for more lectures like this, especially the one you mentioned lately regarding the echocardiography and assessment of valvular heart disease. I know that you have many images and excellent images for this issue. I'm very happy for this nice meeting. I knew that I was sure that it would be a great and informative and precise. I would also like to thank the working group of the CME and for the initiation of this cardiology educational channel. It gives us a great opportunity to meet and exchange the data and the information with each other. And finally, I would like to thank you personally, Dr. Ahmed, for this nice lecture. It's elegant as usual and as expected from you. Thank you so much, and thank you for.
Thank you so much, Dr. Mahmoud, for your kind words. Thank you so much.
Thank you, dear. And we are now at the end of this important and elegant stage of our course of the valvular heart disease course. Thank you so much. Thank you for the YouTube audience. Stay tuned for the next sessions, the congenital heart disease and the intervention session on Saturday and Tuesday. And of course, the next round of valvular heart disease at the next Thursday. Thank you so much. Thank you all.
Thank you so much. Bye-bye.
Bye.
Bye-bye, sir.